So, this is a monitor that basically gives you all the three levers of flow. Preload, afterload, contractility. So it's basically, I like to say it's like a little cath lab right here in itself, all non-invasively. The only thing it doesn't give you is what's going on in the right side of the heart. It's telling you everything that's coming out of the left side of the heart. So this is a perfusion monitor. So the question is, how does it work? I have it on me right now. It's actually working as I'm speaking, so it might have a little bit of a jitter, but so what I do is I hook these, you just attach these sensors to the body, okay? One's an upper and one's a lower. If you want to pass them around, feel free to pass them around. So the upper sensors, I have 2 above the heart, 2 below the heart. It doesn't matter where. It can be on the back, it can be, I have one back here, I have one up here. I'm not going to show you because I'm too fat. And then I have 2 right here. And you can put them on the back as well. So what the upper sensor is doing is sending throughout the torso, this way and this way, an electrical current, a frequency. That frequency is then being recorded as a voltage into this lower. So it's going super, super fast, like a radar gun. So what it's doing is there's a sine wave that's naturally being created. When that sine wave is interrupted with blood flow, so it's called a phase shift in that waveform. It's the distance between that actual sine wave and the phase shift is how much stroke volume is coming out, beat per beat per beat per beat for a whole minute. And then it averages all of those out, and that's what you get for your stroke volume index. Now, we want you to put in age, height, weight for that particular patient because his requirements for volume is completely different than your requirements for volume. So you want to do it on the patient's body surface area, okay? So my weight was 115, my age was 29. But these are my actual numbers, and you go off the indexes. Stroke volume index, cardiac index, TPR, TPRI, you probably won't use. Who's in the ED? Do you start pressors down there? Yeah. Oh, you do? Mm-hmm. So if they're down there quite some time with that pressor, then you would want to manage that TPRI, which is basically what is their resistance. So what you'll want to do is if they're down there quite a while because you can't get a bed, you'll just want to kind of titrate and open them up as you're giving them volume. If they're a septic patient, obviously they're very vasodilated. We've got to clamp them down, right? But then what we want to do is just kind of taper that and get the volume going. All you do is do a map. You just put in that patient's map and it'll give you what the TPRI is. You ever used SVR? We use TPR. They just threw the CVP out of the equation, which really isn't a useful tool anyway. So the numbers are exactly the same, 1975 to 2400 dynes. So they're the same. It's a stagnant number though. You're manually putting it in. Mine are updating every minute. So it's real time. So you got stroke volume, you got cardiac output, and then you can have the resistance, the 3 factors of perfusion and flow. All right? So how do we use this in the clinical setting? The ED, there's a patient that comes in, they have a history of congestive heart failure, they're a renal patient, they look like they need volume, but we're not quite sure. What you can do is assess their volume status before you start fluids. It's just like insulin. You're going to do a blood sugar before you're going to give them insulin. You're going to want to check their volume before you slam them with volume, because too much volume is just as bad as not enough, okay? So you want to keep them in that Goldilocks spot. There's 2 ways of assessing that, and I just did a passive leg raise on me. So what it is I sit in a semi-recumbent position, as you noticed I was sitting, and then for 3 minutes, because all the blood from the heart is going to be rushing down to the calves. Then what you'll do is drop the head down and raise the legs for another 3 minutes. The stroke volume index change of 10% or greater from baseline means that patient's volume responsive. So our CHFers, our renal patients, you can say, I can safely give them volume. Less than 10%, they're fluid adverse. It's not volume that's going to help that patient. So now you can say, what lever do I pull? Do I need to give them a squeeze or do I need to give them a push? But volume is the first thing that you can do quickly and easily. In the ED, some are using the lift and doing the passive leg raise. Some are just starting volume and they're just watching that stroke volume. Is it the stroke volume going up or is the stroke volume going down? If I'm giving volume, my stroke volume index is going down, that patient's not responding to the volume. So why are we going to continue giving volume? And it can work for any type of product, blood, just any sort of volume that you're giving that patient. The other method is you can give that patient a bolus. So a bolus is a big punch to the heart. So you'll have to have a pressure bag, and it's 250 cc's over 5 minutes or 500 cc's in less than 10 minutes. Same exact thing. It'll protocolize after you end the bolus. It'll tell you, is that patient volume responsive or not? So in the ICU setting, we've got this septic patient that's bouncing all over the place. You do it, and you find that they're 11% volume responsive. That's what I am. But I'm a healthy patient. But if they're a septic patient, we don't know, how much we can give that patient. So I'm 11%. So you can safely give me volume, but you probably want to do it on a slower drip just because I was 11%. Or does it mean that you have to give volume? No. It just means that maybe it's the night shift and they always get the people that, circle the toilet at night. So then you could say, well, I did a passive leg raise on that patient. Doc, I did a passive leg raise. They're volume responsive. Do you want me to go ahead and give some volume? But always assess before you give volume. And what I was telling Jason is this is not a spot check because our patients are constantly, our septic patients, their vascular tone is constantly changing. Every time you do an intervention, volume is intervention, their vascular tone is changing. So this is a continuous monitor to continue monitoring that patient until you get them off the cliff and they've stabilized. Okay? So you can customize these screens in the ED. Usually they just want to trend their volume. We can just have stroke volume index on that if that's all you want. The ICUs and the floors are using more medications, so you want to customize the screen for that as well. Every time you do a fluid challenge, it stores. So you can go back. I did this one, and then what you're going to do is give me volume because I can safely take volume. Then you'll give the volume. A couple hours later, let's reassess that patient again. They're just not looking, they're looking kind of wimpy. Let's do a volume assessment. Do they need more volume? There have been patients that have actually been 30% volume responsive. You give them 500 to 1,000 cc's, that was all they needed. Your CHFers are the classic example of, I want to give them volume, I just don't know if I safely can. And that's where the challenge eliminates that challenge and that guesswork for you. Because pressure doesn't equal flow. You can go up on the pressure, but that doesn't mean that you're increasing flow. All you're doing is increasing pressure. What you want to do is manage their volume. It's really easy. You just put in age, height, and weight. It does a self-assessment, and then it's ready to go. The only thing you can't do is leave these sensors on if they're going to go have an MRI. They're CT scan safe, but not MRI.
Okay, educate me. I'm not doing the math right. So your stroke volume index, how'd you come up with 11?
So I did a passive leg raise. I started the passive leg raise. I sat, while you guys were here talking, I was sitting in a semi-recumbent position, sort of. And then what I did is it prompts you. And then it says, okay, now lower the head, raise the legs. And that was another 3 minutes. So what it's doing is that the first 3 minutes is getting a baseline. Okay, it's taking 3 consecutive stroke volume indexes. That's my average. That's my baseline. Then I'm going to raise and give my heart a challenge. And it's about 250 to 300 cc's. And then after 3 minutes, it'll calculate what the change was from the baseline to when that challenge, you gave that heart that challenge.
So where's that on here?
Right here. Right here.
Oh.
It's kind of a picture. This is called the Starling. You can see it has the Frank Starling curve on it.
So that's a percentage change.
Correct.
The level is the percentage.
So 10% or greater, they're volume responsive. And then less than 10% means that's not the lever you want to pull. It's not volume that's going to help this patient. It's our sick patient. I mean, I'm healthy. We're all running around hypotensive. We know we have to be hypotensive, right? But a sick patient, it's like, how do we treat these patients? And what we're going to do is, what's the first thing that we want to do? Give them volume without assessing that volume status first. Questions?
What other utilities have you seen other than, you're talking about shock right now, other than that, any other uses?
CRRT is a big dialysis. So they're not pulling too much volume out.
Yeah.
What they're doing is they're watching their volume status. Post-heart, what they want to do is a lot of surgeons want to pull that swan as soon as possible, but they're not comfortable. And sometimes the patient's going to crump, so they put this on. Like I said, renal, congestive heart failure. Every department in the hospital, you could use this monitor. We use it in for our pregnant ladies that are eclamptic. Pretty broad utility. It's wherever you're questioning their volume status. This is your answer. Immediately.
Other than volume status, what other information can it give you?
So it gives you your cardiac output. So if they're on a inotrope, it'll help you. Plus, if you don't really know the patient's history, that's another thing. You're sitting there digging for a patient's history and we just don't have time, to wait. You can get all this information within 90 seconds. At least you have a good baseline of knowing what is their cardiac status at this point.